Hi guys, what's up? So now we're going deep into the skin pathology. Okay, so we in the last video we talked about the basic anatomy of the skin. Now we're diving deep into the skin pathology. So skin pathology. Let's write the topic here. Skin pathology. While studying this topic, first. Let's categorize the skin pathologies in 4 different broad categories. First one is inflammatory dermatosis. The second one would be the blistering dermatosis. And the third one becomes your epithelial tumors. Your skin is lined by epithelium, so tumors can arise from that. And the next thing you're interested to talk about is infectious infectious disorders, whatever you call it. That's basically infections. So we can categorize the skin pathologies basically under these 4 main headings, and these are basically important from intrinsic standpoint of view. Okay. So out of these 4 things, we're going to talk about this inflammatory dermatosis. So let me erase this. We'll come to this later on. Okay. So inflammatory means there's something going on, inflammation is going on, and dermatosis means there's some problem in the skin. Derm means skin. Tosis means there's some problem in the skin. Okay. Now, under inflammatory dermatosis, we're going to talk about first one, atopic dermatitis. Atopic dermatitis. Or there's next name because they wanted to make it very difficult for us, so they kept another name for it, and that's eczematous dermatitis. Eczematous dermatitis. So, as the name implies, it's atopic, it's allergic, and derm means skin. Itis means there's inflammation of the skin, right? So it's allergic, right? And allergic, it's type 1 hypersensitivity reaction. Type 1. This is how you'll point from exam point of view, right? So in basic science, in MCQs, they're going to ask you this. Which type of reaction is atopic dermatitis? And you need to take out type 1 hypersensitivity reaction, and your 1 marks is confirmed. Now, atopic dermatitis is allergic one, it's type 1 hypersensitivity reaction. And if the patient comes in your OPD, what complaint they will bring? They will bring, doctor, I have itching, pruritus, wherever it is. They will come with a complaint of pruritus or itching, and they will say there's erythema, or you will see it directly. You can see the redness of the skin of the patient, and there will be oozing out. There's oozing of something from the lesion, oozing of the fluid from the lesion, and you'll see visual vesicles. You can see vesicles, and obviously there's going to be edema. Okay, so patient in the OPD will come with this complaint, and you have to first suspect atopic dermatitis. And these patients have high association with the allergic rhinitis or asthma. So you can ask the patient, do you have the past history of asthma, or do you have the history of allergic rhinitis? Most likely he might have, or she might have that past history. Asthma and allergic rhinitis. Okay. So basically, these are the high points. We're gonna have so much discussion about very important diseases more than this. So these are only the highlight points in here. We're not diving much more deep into it. So let's erase it. Now, let's get into another disease, and that's contact dermatitis. Contact dermatitis. As the name implies, contact means you're contact with something, some substance, and dermatitis means there is inflammation of your skin, right? So the contact can be with any substance, anything. It can be substance you have never imagined, right? So different person's skin or body can react to different substances differently. So you can never imagine that. So for example, the common things they're gonna put in the clinical vignettes is poison ivy, or they can put nickel, right? So suppose a patient comes, doctor, my brother gifted me a watch, and I put that watch on my hand for about 5 days, and I got this. So basically what happens is the back cover of this watch has the nickel cover usually, and the nickel causes irritation there, and that may be the cause of contact dermatitis in that patient. Now, the contact dermatitis can be due to irritants like detergents, right? And even it can be from drugs like penicillin. Okay, so now the atopic dermatitis was type 1 hypersensitivity reaction, very high yield point. Now this contact dermatitis, this is type 4 hypersensitivity reaction. Type 4 hypersensitivity reaction, you got it? Now, what's the treatment? A patient comes in the OPD, and yeah, when the patient comes in the OPD, what it brings is the same complaint as of the atopic dermatitis, pruritus. He will bring, something is within from the lesion, and he will bring edema there, and obviously you can see erythema. You can see erythema there, and you can see vesicles. So I see you can see vesicles, right? So patient brings this complaint in the OPD, and contact dermatitis can be because of these things, very high things these are. They may ask in the clinical media, and this is a type 4 hypersensitivity reaction, and how you're going to treat this patient. Let me erase. I don't think you've seen the bottom point. So under treatment, the first and foremost thing is you remove that substance that has been irritating the patient. That is removal of the substance. Got it? And second thing you can do is you apply the topical steroids. Got it? This is the basic treatment in contact dermatitis. Now, these are the important high points that they're going to test you in the overhyped entrance exams. Okay? Maybe in the basic science exam MCQs. Right now, let's get into the very commonly seen case in OPD, and that's acne. So what's acne? Acne means, okay, I will make you understand by discussing the pathophysiology. Okay? Acne means, in general term, we call that pimples. The pimple is just one of the 3 morphologies of the acne, right? So acne can have different morphologies, and then one is comedons. One can be comedon, and next can be pustule, or we call it pimple, and next is nodule. Okay, so how these morphologies, how different morphologies you can see, how these are formed, we're going to talk about that. We're going to talk about that in pathophysiology. So in last lecture, I told you, let's assume this as a basement membrane, or let's assume this for some time as epidermal dermal junction. Okay, so if this is your epidermal dermal junction, and this is your dermis, and this is your epidermis. In dermis, what are different things that are present? Connective tissues, the nerve endings, the blood vessels, and you can find the appendages like hair shafts, and you can find sebaceous glands and sweat glands. So this is dermis, and let me draw one appendage here, that is hair shaft. Now, with the hair shaft comes a bonus, that's hair follicle. And with the hair follicle comes another thing, that's, let me draw with another color so it becomes very clear to you guys. This is sebaceous gland. So this hair shaft is already lined by keratinocytes. Do you understand that? And these keratinocytes, when you hit puberty, there is so much hormone surge. So the hormones will act on this keratinocytes, and the keratinocytes turnover will increase. And when the turnover increases, these keratinocytes will produce more and more keratins. So keratins will be produced more and more in a man. So these keratins will be produced so much in a man that it will block the tube. Now, the tube has been blocked, and at the same time, the hormones is going to act on the sebaceous gland. Here is androgen receptor, and the hormone is going to come here. Hormone acted here, hormone acted here. Now hormone is going to act here also. So now this sebaceous gland will produce more and more sebum, because this has been overstimulated by the hormone. So more sebum will come here, more sebum will come here, and it has to increase in size by rule of nature. When there's something coming in and there's no way out, it has to increase its size. Now look, the hair shafts, the tube has been blocked by overproduction of the keratin, and there is overproduction of the sebum, right? So this hair follicle is increasing in size, so you cannot go out. Here is what you call sebum. So sebum has been trapped in here. So this whole thing which has been expanded in size, it's called comeda. And depending on its color that we see from outside, it's called white heads, or black heads. You get it? So, comedon has already been formed. One morphology explained. Now, this comedon has been formed. Now, there's a general rule of pathology. When there's a blockage in the outlet of a tube, there's always increased chance of infection in the region behind the tube where there's blockage. So here's a blockage, and what I basically want to tell is that there's blockage, and due to this blockage, there's always increased chance of infection in the this backward portion. So now it has been like stagnant water, and here so much sebum is present. So now the infectious agent like Propionibacterium acne will come and it will release lipases. Okay, let me draw this picture a little bit bigger, so we'll have more space to talk. So let me extend this comedon this way so that I'll have more space. So this is comedon, white head, black head, as per the color again. Now, yeah, when there's blockage in the tube, then the normal flora of the skin, the Propionibacterium acne, will come in and it will release lipase. And this lipase, what it will do is the lipase will act on the sebum, and the sebum will get broken down into pro-inflammatory fatty acids. Pro-inflammatory fatty acid. When it's pro-inflammatory fatty acids, it causes inflammation. Right? So when inflammation happens there, it's called pustule, or simply we call it pimple. So second pathology has been explained. Second pathophysiology has been explained. Now, when scarring occurs in this pustule, you get nodules. You get it? So comedons explained, pimple explained, and nodule explained. Right? Now, what's the treatment of acne? A patient comes in the OPD and he says, I have so much acne since so many months and I'm so much frustrated. How I can get treated, doctor? Please tell me. He tells you in that frustrated voice. And let's explain how the two major medicine options are works in this patient. So we have two places to interrupt in this whole process. One step is here, and one step is here. All right, let me use a distinct color so your eyes can get rest. So one space is here, and one is here. So the main problem here is the keratinocytes has been responding to the hormonal surge. So what if we maintain these epithelial cells? What if it doesn't produce so much keratins? So we use vitamin A derivatives. So what vitamin A does is it maintains the special epithelial lining of this body. So this keratinocytes turnover rate is decreased and the keratin production rate is decreased. So the keratin will not be producing more amount, and it will no more block the hair shafts. Now the outlet pathway is open. So in this way, vitamin A derivative work. And vitamin A derivative example is, one famous example is isotretinoin. And next options we have for the patient is, we can give one number and let's talk about the second option. And the second option is benzoyl peroxide. What it does is, it directly kills this bug. This bug has been the main culprit in causing this inflammation, right? So this bug has produced lipase, and this lipase is converting sebum into pro-inflammatory fatty acids, and this pro-inflammatory fatty acids is causing the whole inflammation thing. And the inflammation, when it occurs, that causes nodules. So if we kill this bug, then we will not get two other morphologies, that is pimple and nodule. Right, so the treatment of acne is vitamin A derivative, and the next one is benzoyl peroxide. You get it? So I don't want to make the video very long, so next inflammatory dermatosis we're gonna talk in next video. Now I'd like to stop right here. Thank you. See you in the next video.